I was asked to talk about pediatric bone fragility, so we will not confine ourselves to osteogenesis imperfecta, but we'll spend more time on it. So I think the most important thing that you need to think about is what is going to happen to children that you see with bone fragility disorders. How strong are their bones and how did it get there? Even though the bones may be fragile, you still have to consider normal accrual of height and bone development in order to maximize bone strength and to minimize those problems that you might be able to avoid. And you've seen this slide before. As children grow, their bone mass increases at the same time. Men have lower bone fragility than women because their peak bone mass is higher, their femur size is bigger, and so even if they have the same adult insult to their bone, the loss is less compared to the percentage of bone that they have. And if you consider the difference between women, they have smaller, thinner bones, and so when they get osteoporosis or have an insult such as glucocorticoid in adulthood, they perforate those trabecular plates, the connectivity decreases, and osteoporosis is earlier and worse. So specifically, women also have extra risks to their bone mass. Their peak bone mass is lower, and they have a number of insults during life that will potentially reduce their bone mass further. So if they have a bone fragility condition, it will be worsened by pregnancy losses, lactation, and finally by menopause. So these are all things that if you're treating children, you have to keep these things in mind for the future. We all know how to do a bone density, but the important things that we'll add to later in the day will be that you have to look at the correct site. You must use the correct software. Having a wonderful DEXA machine and using adult data or software, you might as well tear up the results. You have to adjust for the size of the patient. You cannot compare a 10-year-old this high with a 10-year-old this high. Doesn't make any sense at all. And most people don't correct for height. So you're already reading nonsense out of a very clever piece of equipment. And you have to have reference data that applies to your population, not somebody else's. Sometimes you can't interpret the X-ray or the bone density. On the left there, you can see vertebral fractures. In the middle, it's not so easy to see the fractures, but they're still visible. And on the right, somebody has interfered with this patient and put a lot of metalware in there. You can't do bone density when there's metalware present. And the patient's complaining of severe back pain. And sometimes the only thing you can do is a technetium scan, which will identify the hotspot that says, yeah, they weren't making complaints for nothing. They actually did have a fracture, but you couldn't see it. If you're lucky, you might have a PQCT machine, which will look at cortical accrual, and you'll be able to see whether somebody who is immobilized, particularly, is accruing cortical bone, or whether the main reason for their fragility is that they have a very thin cortex. If you have a useful bone density, you can make use of it with lateral vertebral morphometry. And you can see both on the left, where a patient has severe osteoporosis, on part B, where there's very difficult to see the bones at all, and you do lateral vertebral morphometry properly, you can see them beautifully. And on the right, there's so much metalware in the way that you can't see it as well on an X-ray, but you see what you can better with vertebral morphometry. So you've got several ways of utilizing your equipment. And if you're lucky, you may be able to do a transiliac, a bone biopsy, which will tell you the difference between normal lamellar appearance of bone at the top and something very different like type 6 OI at the bottom. So what you want to know is this child having fragility fractures? So here we have 3 children. First, we want to know, how did the fracture occur? Where did it occur? Was it at school, at home? Was it a twist? Was it a fall from the bunkie bars? Did they just fall to the ground? Age of first fracture, chronic health diseases, any medications such as anticonvulsants and steroids, and a family history that might be helpful for you. And if you're thinking of questions like osteogenesis imperfecta, you need to talk about eye disease, and if anybody in the family died of aortic dissection as well. So this was well demonstrated in the case that's just been presented. The history was extremely good, and we excluded most of these other conditions simply by asking some questions. Then you can examine the infant to see whether there are clear signs that suggest osteogenesis imperfecta, whether there's only ligamentous laxity that might make the child fall over easily, whether the skin is abnormal or stretchy, suggestive of something like pseudoxanthoma elasticum, whether there's skeletal deformity or a cardiac murmur, and then you can add some special investigations, which we've mentioned before. So what do you need to know to accurately assess these bone densities? Here's a 9-year-old male. He's had 5 low-impact fractures over 3 years. They've been quite serious, 2 in the femur, 1 in the tibia, 1 humerus, 1 radius. Clinically, it's perfectly normal, nothing to find. Nobody in the family has had problems. His bone density Z-score is a little bit low, and the hip is supposedly minus 1.3. My recommendation is that you don't use the hip in young children. It varies enormously, and you get extremely misled by those results. Here we have a child with a 13-year-old girl who has severe cerebral palsy. She's had a no trauma femoral fracture that occurred in the school. Nobody can tell you why it happened. She's fed by percutaneous gastrostomy, and she's taking 4 anticonvulsants. Her bone density Z-score is minus 3.2, and her hip is nonsense. And here we have an 18-year-old girl with severe OI. She's had lots and lots of fractures. She's been treated with zoledronic acid for 10 years, and her bone density Z-score is minus 5.6. What is common to all of these patients? What do you need to know that makes you able to try to interpret these patients? Any offers? Quick. Height? Height. And puberty. So without knowing how tall they are, whether they've gone through puberty, whether puberty started and whether it stopped, will make it possible to interpret this otherwise complete nonsense. On the right, that Z-score of minus 5.6 in a girl who's had 40 fractures, she's probably only about 120 centimetres high if she's lucky. So it's not really minus 5.6. You have to adjust for height. For the severe cerebral palsy girl, her lumbar spine is low because she hasn't gone through puberty. And for the 9-year-old boy, he's very tall. That means that the bone density, which is minus 0.5 compared to a normal child, might be minus 2.5 for a tall child. So without that data, you can't interpret things at all. Biochemistry markers are largely useless and mainly reflect growth or a recent fracture, like that patient you saw who had a high ALP in relation to a fracture. You can do lots of tests. The only one that's really helpful, I suppose, is a vitamin D. You need to do other tests to exclude chronic disease. There's nothing to stop a patient who has osteogenesis imperfecta also having celiac disease. And you might need to know, say, for the cerebral palsy girl, is she going through puberty or does she have pubertal arrest? And you need to know when you're thinking about your patients what you can possibly achieve. The more unhealthy that young person is in terms of their physical disability, the less you are likely to be able to achieve in final outcome. Neither of those patients with OI on the right will ever achieve a normal adult height. Their fracture risk will continue to be permanently elevated throughout life, no matter what you do, because fractures are related to load, strength, and geometry. So you try with growth, you try with puberty and nutrition. If they can wait there, that would be a good thing, and then use bisphosphonate when it's needed. So we're going to go through primary and secondary causes of fragility as quickly as we can. We know that OI, brittle bone disease, is abnormal bone development with a low bone mass and increased bone fragility, with collagen mutations that disturb the bone assembly. Generally speaking, they're COL1A1 or COL1A2 with dominant mutations affecting the synthesis and structure of type 1 collagen, and the recessive ones affecting post-translational tracking. And they're all characterized by poor bone mass and disorganized bone with high bone turnover. I think the Salent's classification of type 1 to type 4 really doesn't apply anymore. It just means it's more severe or less severe in some cases. The very first patient I ever saw actually had type 1 with a COL1A1 mutation. She'd had 150 fractures when I first saw her. So I don't think you can use this classification effectively. What I find is easier is to think about the tracking process. If there's a haploinsufficiency of COL1A1, there's less collagen. The structure is normal. If there's a missense mutation, there's a structural change, there's instability of the collagen, and for extracellular interactions. Later on, you have initiation of chain recognition and helix folding with the more recessive problems like CR-TAP, lepre, quality control, like the patient you just saw with the SERPIN-F mutation and FKB10 mutations. So this affects the collagen transit to the Golgi. Then you have modification of COL1 with COL2, bone cell formation and mineralization, SERPIN-F. So I think you need to think about those possibilities in terms of what you're doing. Do we need to undertake genetic testing? Sometimes the clinical picture doesn't give a proper diagnosis. Femur and tibia fractures are much higher than the population, particularly in adults as well as children, and the majority of people with some form of OI have femoral fractures at some time in life. Mutations affecting C-propeptide with COL1A1 have hip dysplasia quite often. Glycine substitutions in COL1A2 may predispose the patient to intracranial hemorrhage. If you don't know that, it's a bit difficult to look after your patient properly. PLS3 and some of the others have X-linked fragility with glaucoma and aortic dissection. And we recently had a patient die unrecognized at the age of 24 of aortic dissection because we didn't have the genetics. There are lots of gene loci for progressively deforming OI. They differ in different populations, as you can see. So the question is, does the genetic diagnostic help? Does a genetic diagnosis help? And I think that it really increasingly is absolutely essential where it's possible for you to undertake it. It's really easy if you can see blue sclerae and dentinogenesis imperfecta, but that's only a relatively small number of the population. If you call it the old type of type 3, they're just patients who have severe deformity, and they have a likelihood of basilar invagination if they're not treated. Type 5 is really important because they have a very high risk of developing hyperplastic callus, as well as their fractures. And that can occur in the context of a fracture or outside of the context of the fracture. And so if you're not aware of that, and suddenly the patient presents with a huge swelling of the leg and looks exactly as if they have osteogenic sarcoma as the underlying diagnosis, they might end up minus that leg if you weren't clear in your underlying understanding. The FKB10, BP10 mutations have awful protrusio acetabuli, so they end up not being able to walk very easily. The type 6 serpin F mutations, like your patient, has pigment epithelial-derived factor PEDF1 undetectable, and they have a mineralization defect. That was the bottom of those 3 pictures of the bone biopsy that I showed you. They have a very distinct presentation with no fractures in the first 6 months of life. They don't respond very well to bisphosphonates. And those are the patients who might do well using a RANK ligand inhibitor. So that patient that's just been presented, you can see has continued to fracture. One of the main reasons, of course, is that the child has not had the opportunity for stabilization of the limbs with rodding. And so every time he moves now, he's fracturing. But maybe the treatment is not optimal. If we can obtain a sclerostin antibody, which we may be able to do soon, this may be a better treatment for this particular condition. You should remember with all your patients with OI that collagen defects affect the cornea as well. And these patients develop glaucoma with monotonous regularity. Everybody knows about the hearing deficits in OI and to send the patients to see an audiologist, but they forget about review of the eyes. So all patients with OI should be screened for glaucoma and corneal abnormalities, particularly those that have specific risks. So, as we said, we diagnose the OI on 1 vertebral fracture, 2 long bone fractures under the age of 10 or 3 under the age of 19. We need a family history, an examination, and a bone density. Sometimes we can make a very quick diagnosis as the patient presents for the first time to an emergency department by taking a skull X-ray and seeing worming bones. And this may be very important for patients where the question might be non-accidental injury. And so you can make that diagnosis within 15 minutes of arrival in your department. The molecular genetics remains important to define surveillance. So we can't help scoliosis because scoliosis is due to abnormal collagen in the ligaments as well. It continues regardless of treatment and ends up leading to restrictive lung disease. Please look at your patients carefully. This little boy looked completely normal. He looked pretty normal side on, but he had a significant scoliosis from the back. Joint hypermobility leads to pain and disability, as well as increased risk of falls. And management is multidisciplinary, and you can't do it all yourself. You do have to have the surgeons, the social workers, the physiotherapists, and family support. You need to have the best quality orthopedic devices for intramedullary rodding, problems being rod migration and fracture and delayed healing. So you need a fascioduval rod or something similar that will expand as the child grows. It may be the more recent uses of denosumab and other drugs as well, as I mentioned. So let's move quickly, because I haven't got much time, to secondary osteoporosis with immobilization and disability. There are lots of reasons why a child might be immobilized. Cerebral palsy, some disorganized brain disorder, either congenital or acquired spinal abnormalities with paraplegias and hemiplegias, neuromuscular disorders, and rare genetic problems, as well as OI. Things that are very useful to help you with examination, again, is the size of the patient, the height of the patient. And remember, when you have a paraplegic patient, that they will be short, but only short below the level of the injury. So the upper half is normal, and you'll make a mistake in your assessment if you don't recognise that. You also need to look at other questions of rickets and pubertal status. And remember that they can all have other conditions. Delayed and arrested puberty is my hobby horse, and they all need to have pubertal assessment and management. We know that chronic illness results in poor nutrition, therapies interfere, reduced in mobility, reduced sun exposure, all reduced bone mass, and it's compounded by vitamin D deficiency. I don't need to tell you this, but I want to remind you about the determinants of bone strength, which are load, geometry, mineral deposition, all of which decrease during illness and immobilization. There's less weight bearing, less muscle load, increased calcium losses, and increased cytokines. And there's a lovely picture given to me by a rheumatologist years ago, looking from left to right over a period of 10 years. This child with rheumatoid arthritis, bones got smaller as they got older. The clinical consequence, of course, is bone pain and fracture and failure of orthopedic devices. So who do we treat? Here's a 14-year-old girl with severe cerebral palsy, peg-fed, multiple anticonvulsants. She's had a fractured femur at school. You need to know whether another child fell on her, whether this was a traumatic event. Did she fall off the trampoline? Did somebody tip over the wheelchair? Often the staff won't tell you. Is she vitamin D replete? How tall is she? Is she very thin? What's her pubertal status? And probably the best thing you can do to this young person is induce puberty, because you will induce 50% of increase in your bone mass for life. Compare that with a 16-year-old girl, again with severe cerebral palsy, who's eating normally, not peg-fed, doesn't have epilepsy. She's had menarche, although it was late, and she's had 3 periods to date. Her bone density, lumbar spine Z-score, is minus 3.1, but if you correct for the fact that her menarche was only 3 months ago, in a short girl who was in the bottom 10% of our population for height, her Z-score is actually plus 0.4. You don't need to do anything. So what are the problems? It's really hard to assess puberty in patients who have contractures or who are heavy or who don't have a hoist. The family can't lift them on the bed. You've got 10 patients waiting in your outpatients and you don't have time. Taking a history of pubertal status, I find, is completely useless. Holding up a card, they'll tell you anything. Don't believe a word of it. Disorders like cerebral palsy or disorganized brain, as you know, often develop pubic hair age 4 or 5 years. This isn't puberty. It's a raised DHEAS in the context of the brain disorder. But again, if you ask a question, the parent will tell you they're halfway through puberty. So don't believe it. Take the time. If you don't do regular physical checks, you won't develop pubertal, you won't detect pubertal arrest. In addition, as I mentioned yesterday, 50% of young adults with cerebral palsy will eventually develop hypogonadism because their bodies are too sick to maintain their sex hormones. And that applies to people with chronic diseases as well. The consequences are severe: increased fracture, poor muscle maintenance, and reduced social interactions. How does glucocorticoid growth cause growth failure in chronic disease? It inhibits your DHEAS, so there's less pubertal onset and puberty is delayed. Growth hormone release and IGF-1 bioactivity are decreased. Chondrogenesis is decreased with less collagen synthesis, and vertebral fractures, of course, contribute to growth failure. But I don't know how many of you have been asked to see a patient with Duchenne muscular dystrophy. The neurologists tend to keep them to themselves, but you need to educate your neurologists that this is this huge problem. Most of these patients are taking the equivalent of 25 milligrams of prednisolone a day. They have hopeless growth failure, as you can see in the growth chart. They have massive incapacitating weight gain. Puberty cannot possibly occur in somebody taking 25 milligrams of pred a day for years on end, and they have multiple vertical fractures by the time they get to see you. What can you do? You can induce puberty. And all I want you to see here is the use of pubertal induction in delayed puberty, which we published a couple of years ago. Generally speaking, if you use bisphosphonate for those fractures, you'll increase bone mass very slowly. You'll get 2 to 5% per annum improvement in bone density compared to no use, where you'll get 2 to 5% loss per annum. If you induce puberty, you'll get 12 to 24% increase in bone mass over 2 years. So you can imagine that these young men who are now probably going to live for much longer than they used to are now going to have less fractures, less pain, and a better skeleton to deal with their chronic illness. Oral glucocorticoids have horrible effects. Here's a 14-year-old boy who had nephrotic syndrome from the age of 6. His parents said that they had been given a new treatment over 6 months where he'd stopped growing and had weight gain. What did we find? What did we find? We certainly found vertebral fractures. What else did we find? He had Cushing's. But he also had, for his mid-parental expectation on the 50th centile, he was on the 3rd. So it didn't actually happen all over 6 months. What they'd done was that they'd taken their child back to home to Kerala, and they'd been given some special new medication in a powder form. It was high-dose dexamethasone. His morning cortisol was low, his ACTH was undetectable, plus he had vitamin D deficiency, and all we had to do was stop the dexamethasone, send him to the renal physicians to make sure that the nephrotic was under control, and he got much better. And there we have a fragile infant. You will recognise this baby with biliary atresia who's about to have a liver transplant. At the time of, if he's lucky enough, having a liver transplant, he's only got about 10% of his adult bone mass. He'll only have a few months, if he's lucky, of high-dose steroids to keep the liver in place. And they may even be intermittent after that, or not at all if tacrolimus or something similar works for him. The impact of the steroid on his bone mass, therefore, will be relatively small. But babies like this don't grow. You can't see rickets, but they have rickets because they don't have a functional liver, they don't have any vitamin D, and nothing gets to their bones. They have teeny tiny little bones, and then they get a hit of steroid after the transplant, and they break everything. So they may appear 6 weeks post-transplant. You're called to see them. They've got 2 fractures in the arms, 2 in the legs, and half a dozen rib fractures. But the net result is if you give them a little bit of treatment, if you're lucky, you might be able to give bisphosphonate, but you really have to ask the transplant team first if that's okay. But their outcome will be absolutely fantastic. And they will have normal bone mass if their liver survives by the time they're adults, because 90% of the bone mass has not yet been accrued. So the aims of management in chronic health is to complete the normal physiology, to prevent future deterioration and loss of function, to be able to predict future problems such as glaucoma, aortic dissection, and thus reduce the risks. Very importantly, we need to transmit sufficient knowledge to patients to understanding their ongoing needs and their future needs. And we need to make sure that our staff are educated to facilitate action.